Afternoon session. Live cases are coming from the Institute of Cardiovascular Diseases, the Madras Medical Mission in Chennai, led by Dr. Sivakumar and team. I think Sivakumar doesn't need much introduction. He's a very versatile and highly talented interventional cardiologist with a lot of experience in complex heart diseases, and we look forward to see him managing some complex cases. First one is pulmonary valve implantation in severe pulmonary regurgitation. Second one is device closure of ruptured sinus of Valsalva. Third is a device closure of perimembranous PSD, and then a discussion on and management of a patient with the right-left shunt across a PFO with RV hypoplasia. And we have our esteemed panelists here, Dr. Mahava Roy from Rabindranath Hospital, Tagore Hospital in India, it's Calcutta, and Dr. Johannes Nordmeyer from the German Heart Center, Berlin, Germany, and Vivian Diamonds from the Medical City Children's Hospital, USA. Welcome.
Hi, Joseph. Nice to hear you. And can you see us and hear us?
Siva, can you hear us?
Mario, I am able to hear you very well.
Okay, very good, very welcome, and we look forward to seeing you doing very interesting cases for sure. So, go ahead.
Sure, thank you, Mario. Here we have Dr. Srija, Dr. Pramod, and a team of people who are assisting me. The first case will be a pulmonary valve implantation. It will be presented by one of my colleagues. PowerPoint, please.
Our first case is venous P valve implantation for severe pulmonary valve regurgitation. Our case is a 13-year-old boy who has complaints of effort intolerance class 2 for past 6 months and progressive increase in RV volume on cardiac MRI. He was diagnosed with tetralogy of Fallot in infancy and underwent intracardiac repair with transannular patch at 1 year of age in 2009. And subsequently, he underwent LPA balloon dilatation at 3 years of age in 2011. His X-ray showed a CTR of 58% with RA enlargement and RVOT enlargement in the left arch. His ECG showed a sinus rhythm with normal PR interval of 160 milliseconds, complete RBB pattern with QRS duration of 120 milliseconds and axis of 90 to 105. His echocardiography showed intact VSD patch, severe pulmonary regurgitation, and dilated RV with adequate biventricular systolic function. His cardiac MRI showed severe PR with PR regurgitant fraction of 52%, RV end diastolic volume indexed 174 ml per square meter, and RV end systolic volume indexed 83 ml per meter square, RV to LV end diastolic volume ratio of 2.5, RV ejection fraction of 52% and LV ejection fraction of 51%. His RPA to LPA flow ratio was 60 to 40%. The following images are CT pulmonary angio images. The axial cut showing a pulmonary annulus of 28 mm and a distal MPA measuring 30 mm and LPA origin stenosis measuring 13 mm. These are the sagittal, axial and coronal cuts, dimension showing annular dimension of around 28 to 30 mm. And these are similar images with the same annular dimension of 28 to 30 mm. This is the RVOT angiogram lateral view indicating severe RVOT dilatation and severe PR, and the proximal RVOT measuring 28 mm, mid RVOT 28.5 mm, distal RVOT 31 mm, and the RVOT length of 30 mm. This is another RVOT angiogram in RVO cranial view with the proximal measuring 28 mm, mid RVOT measuring 32.5 mm, distal measuring 34, and 30 mm long. The balloon sizing of RVOT was done with the lateral view. The waist diameter was 31 mm, and in IO cranial it was measuring 30 mm. The coronary angiogram to rule out LMCA compression showed no LMCA compression, and RCA angiogram also ruled out RCA compression. So the maximum balloon waist was 31 mm. So now we'll go for live demonstration of venous P valve percutaneous implantation.
So Mario and Joseph, you would have heard the story. The indications of the pulmonary valve replacement is met because the right ventricular volumes indexed are more than 175, and the right to left ratio between the right ventricle and left ventricle is more than 2.5. The pulmonary regurgitant fraction is almost half of the blood volume is regurgitant. So he becomes a candidate for a pulmonary valve. Any questions about the indications?
Yeah, I think the indication is quite clear.
Okay.
Are there any questions from the audience for this case?
Mario, the issues that has been highlighted is that the left pulmonary artery needed a balloon dilatation at 3 years of age, and now the left pulmonary artery ostium was measuring 12 millimeter, while the hilar pulmonary artery was 24 millimeter.
Yes.
The MRI predicted...
That's exactly the question I wanted to give you. Are you going to treat the origin of the left PA before implanting the valve, or what?
I think that is important, because we are planning to bring the valve initially deployed in the left pulmonary artery and pulling it down, because the left pulmonary artery was in direct line with the right ventricular outflow tract, and hence it will be better if I get the left pulmonary artery ostia in balloon interrogated, probably with a full dilatation. So with that in mind, we did one LPA angiogram now, this time. Can you show the picture? Okay, this is what we have also done is the left coronary artery, the catheter, we were not able to get a stable position. The left coronary, it was a very dextro-rotated aortic route with a posterior origin of the left coronary, and our catheter was frequently slipping out, and hence we decided to put in a coronary wire in order to stabilize the catheter there, which will allow us to check the coronary when we want it. Of course, we have done it before during the balloon interrogation and it was fine, but to engage the left coronary was a little bit difficult, so we have wired it with a balanced middleweight 014 wire and kept a guide catheter in the aortic route. Next picture. So we went into the left pulmonary artery and we were not able to identify a good branch deep inside. So we made a small flush angiogram, next picture, and then identified a good vessel. This is the left pulmonary artery angiogram. Because of the pulmonary regurgitation, the contrast is getting washed away. However, I can show you a still picture. Show the photo. So the left pulmonary artery ostia was around 12, hilum was around 21, 22, and the right was around 24. So we thought we will inflate a balloon across the left pulmonary artery origin and then see whether it is completely like giving way. Is it a compliant lesion? Would you agree with our plan?
Shiva, I have one question about the LPFO on MRI. You said there was
60 to 40.
46,
Yeah.
60-40. So there is
Minimally.
not significant difference between the flow between the right pulmonary artery and left
Yeah,
pulmonary
yeah.
artery.
So the
Second question.
so I agree, Joseph. The problem is not for the perfusion of the left lung, which reasonably is adequate, but when we are deploying the valve, the distal flare is conventionally opened out in the left pulmonary artery and it is slowly pulled into the confluence in a venous P valve because it is a self-expanding valve and it shortens significantly. So unless...
Let me ask the panelists if they have some questions about this issue. You have the microphone? Yeah.
Angio?
Hello, sir.
Yep.
This is Dr. Mohua from R.N. Tagore Hospital, sir.
Yeah, Mahua.
Sir, is it really needed, sir? Dilatation of the left pulmonary artery, is it really needed?
Okay. Okay.
Already 60-40 circulation is going on.
Okay. I was explaining that in order to get the valve distal flare fully opened across the left pulmonary artery and to pull it back into the main pulmonary artery, we will be needing a wide opening of the LPA, otherwise the flare will not re-enter. The venous valve is designed in such a way that unless, get me more contrast, go inside. Unless I get a wide open LPA origin, go to the, I will sometimes not be able to get the carrot out. Mario, you would have used a lot of venous P valves. What is your opinion? Will it be?
Well, but it looks like that is very, very compliant lesion.
Yes.
The balloon is inflating up to, I don't know, 20 millimeters or something like this.
Yeah.
So that's a very low resistant waste.
Yeah. So we are happy about it. So now we are probably all set. Keep it inside. All set to take the valve inside. Now since we got...
Did you repeat the angiogram after balloon inflation?
No, since it is widely opening, I am not doing it again, Mario. Do you think it is important? Because I thought if there is a residual significant waste, I will do an angiogram. But I agree with you that it is a very compliant lesion, and so it is easily giving way. So I'm happy to just take the valve directly inside.
So the plan is to put a venous P valve, right?
Yep. So
and what about the size of the valve you have chosen or you want to choose? Or there are any comments from the audience or the panelists about the size of the valve to be used?
The balloon interrogation, the balloon waist was 31 to 31.5 millimeter. And hence we are planning the largest 36 valve because it's usually 4 to 5 millimeters larger than the balloon waist that we take. We did a balloon testing with the Amplat's sizing balloon, which is a compliant balloon. And hence we would like to go 4 to 5 millimeters larger, which makes it 36 diameter. How many of you would like to have a 36 for a balloon waist of 31?
Who's in favor of the 36 millimeter valve? Everybody agrees with that? Probably yes. But there is a very important question. The left or right pulmonary branch to be chosen for deploying in the valve. You have the wire in the left PA, but why to use the left PA and not the right PA? Taking into account that the right PA is much larger.
Yep.
And probably the direction of the RV outflow tract is more favorable going from the right PA instead of the left PA. Or at least this is my question.
In fact, we felt the other way, Mario. This RVOT was more in line with the left pulmonary artery. I will now show you, disable the injection. I will show you the line of my guide wire. See, it is in fact straight going into the left pulmonary artery. And so we felt, based on the CT, MRI, as well as the angiogram and guide wire position, that this patient is more in line with left than with right. What is Mario? What you have any strong opinions?
Well, actually, no. I mean, you advance the delivery system very easily to the left PA. Probably you would have done the same, the right PA. I think the question is whether what is going to be the appearance of the valve when you start deploying. That we see.
Do you another 10 at 15?
But certainly the risk of occluding the right PA is close to zero because it's huge.
Yeah. So, any other panelists, any other questions?
There is a question from Johannes. Wait a second. Johannes.
No, that's not a question. I totally agree with you, Mario. I think that's an important consideration to make, whether or not there is a risk for obstruction, because the device, of course, is fully covered. And you cannot really predict what the flower looks like when you deploy the valve. And of course, if you've got some space, that's certainly something which is good for you.
Are you concurring that left will be better?
No, the question is whether
just a general consideration about the issue to be careful not to
15 at 15
of the contralateral pulmonary artery. But
yep.
you already started to deploy the distal portion of the valve, right?
Yeah, we have deployed it in the left pulmonary artery. I'm going to fine adjust now. So now I have the distal flare, which is the open portion of the venous valve within the left pulmonary artery. I will probably deploy a little bit more and then slightly get the valve towards the, you can see that it's slowly getting opened better and better. Inject again.
Don't you want to pull the device a bit back because
I'm
cannot
going to
deploy completely there?
I'm going to do that little bit.
Yeah.
At this position, I will open a little bit more. Angio. My covered portion, the covered portion is covering the right.
Is still constrained into the left PA because it's small.
Yes.
You have
yes.
to get back a bit more.
So I'm going to do that. That is the portion. That is the portion which is the left pulmonary artery, which is a little narrowed. Inject.
Still constrained. The deployment is not allowed due to the size of the left PA.
Yeah.
I think.
Yeah, correct. So now we have got it.
Now.
Inject. So now come to RAO. You have to be ready. Okay. Come to RAO and Srija, come this side. Hold. Ask Srija to hold these two. Come that side. RAO. Make,
you have, okay.
make an angiogram. Okay, now, Pramod. 1 second.
Are you happy with the appearance of the distal?
1 second. 1 second. 1 second. Now, do an angiogram.
Yeah. Actually, the stent reconform a bit better.
Okay. Now, come to elevocranial. We have to load our injector a little bit. Show the. Okay. No, give it back. I want injection now. Give 15 at 15. Ready? Okay. So come back to RAO. So now the valve is getting oriented more towards the inflow. So Pramod, can you start deploying? Okay, same RAO. Yep. Yeah. Yeah. It's going to fling open. Yep. Once again. Okay. Okay. Now, make an angiogram now. Actually, our pigtail is trapped on the side, but I will make an angiogram and then take out the pigtail.
Okay.
Okay. Go to elevocranial.
You're not worried about the pigtails to remain entrapped into the stent?
I will take it out, Mario. I will just check it and then take it out. I'll put a wire and take it out.
To remove it with a wire inside or right?
Definitely with a wire.
Thank you.
So now get a Termo wire. Load contrast now. So I'm getting my wire across. So now I have my pigtail in the right ventricular outflow tract.
Very good.
Let me check one angiogram now in this right ventricular outflow tract. And then I have to concentrate whether I have the two eyes of my pulmonary venous P valve already released from the delivery system. So now ready for injection? The position here looks okay to me.
Sorry.
Yep.
Shiva, there is a question from the audience.
Yeah.
Yes,
Yeah.
I think it's no complete release.
Okay.
You have to see another hole.
I will full release, only release. Yeah.
Yes, the question is that the proximal portion of the stent is probably not fully released yet, so you have to be careful before retrieving it, because you take the risk of pulling everything back into the right ventricle.
Come to RAO. Come to RAO. More cranial. Okay. Ready for another injection. Okay. So now we have to see whether we have released the eyes. Come here, Pramod. Okay. So now we are going to concentrate on the two eyes. Come to AP view. AP. No, AP is not showing. Go back to LAO. So now I am going to use a cine in order to find out whether I have released the valve fully. No injection. No, you load.
Excuse me.
Yep.
Ivan, can you show us for a second for the audience your hands and the delivery system, how it works, just to say very, very briefly?
Yeah. Can you show it here? So in order to find out whether I have released or not, I am gently giving a rotation on my delivery system. I am able to see one eye here. Another eye also I am able to see. Mario, I have seen both the eyes. One is at 9 o'clock and another is at 3 o'clock. Are you able to see that? Magnify this. Magnify. Fully magnify. Now you see that there is one eye very close to the delivery knob, which is already released.
Yes.
And the exactly opposite to that, at 3 o'clock, I have another eye. So I'm happy about the knobs. Mag down, mag down, mag down. So now I am going to slightly see whether I can move my, okay, come to RAO. Fluorostore this.
All right.
Come to AP view. Show the resheathing. So now you can show my hand.
Yes, we see that. Very good.
Okay.
Very nice.
So now I am taking out the sheath. I want a pigtail here. Get the pigtail.
Excellent. Can you tell us the French size of the sheet which is inside the vein?
The French size is 24.
3-4.
2-4, 24.
24.
Yep.
2-4.
Show the valve now again.
Now you're going to advance the pigtail in the PA. You're doing a pulmonary angiogram? Or
yes. First I will check the pressures. See the gradient, diastolic gradient between the left, put the pressure on the right ventricle. The marker pigtail is on the right ventricle. The other pigtail is now going into the pulmonary valve. Can you show me in RAO? So I have two catheters, one in the right ventricle and one in the pulmonary artery. So while my colleague is getting both these calibrated, I am looking at the coronary artery. Come here, Pramod. Do it. Get me contrast here. Can you get both these sorted out? I want the hemodynamics. Go to Elevo caudal. Caudal. Okay, there is no coronary obstruction. So I am disengaging the coronary catheter and taking it out. Now come to RAO again.
Shiva, do you routinely do the coronary angiograms after the valve implantation, or this is because of the slight anomalous origin of the coronary artery?
Actually, it is safer to do it because when the patient post-procedure complains of a chest discomfort, I feel it far more reassuring for myself to have seen the coronary artery immediately at the time of procedure, so that I will be much more happily reassuring him. It's quite common practice that I have seen.
It is for your coronaries than for the patient's coronary.
To some extent, yes, I would say that, Joseph. The same thing happens with an AST device closure. Sometimes when you do an AST device closure, in a patient who is say around 35 to 40 and then they complain of chest pain, you always have a lingering doubt at the back of your mind. So it's better to shoot one. And since some of the balloon expandable valves are known to cause coronary compression, so this is the hemodynamics now. Make the hemodynamics big. I'm seeing quite a good diastolic gradient. I will slightly pull it out. Okay. So there is a nice diastolic gradient. Show the hemodynamics big. Yeah. So Joseph, it looks nice. What do you feel?
Excellent result.
So I'm going to make one angiogram. Now in the distal pulmonary artery, go to elevocranial. About 5 millimeters of mercury is there, Joseph. But the problem is my pigtail is into the left pulmonary artery. So that could be causing a little bit of gradient. Now I'm slightly pulling my catheter inside. Come down. Give 25 ml at 18 rate.
Excellent. Very excellent result. Congratulations, Siva and your team.
Thank you. Now,
a big applause to them.
I will again show the hemodynamics because now I have come out into the main pulmonary artery. Connect it.
Well, the result is hemodynamically perfect. But let me ask you a question.
Yep.
The distal portion of the stent is a bit, well, not really very nice because it's protruding into the origin of the IPA with no consequences because the flow is perfect. But don't you think that deploying the valve started from the IPA could have been result in a better orientation of the device? That's just an hypothesis.
Actually, Mario, let me show you the picture bigger. Show this angiogram. The entire flared portion of the right pulmonary artery, entire flared portion of the venous valve is in the origin of right pulmonary artery. Allowing freeze it now when the RPA is feeling better. Stop. So now Mario, here you can see that the whole of the open cell of the venous P valve is now exposed to the right.
Yes, absolutely. The flow is perfect, no question about that.
Yeah.
Shak Qureshi has a question or a comment.
Shiva, just on Mario's point, have you got a lateral projection as well?
I will do that now.
Of this?
I was waiting for you, Shak. I will do it now. Get into.
Because it may look slightly uncomfortable, but hemodynamically it works. Distal flare is uncovered, so the
lateral
flare uses the branch pulmonary arteries as an anchor.
Yes. It also depends on the great discrepancy of the size of the two branches in this particular case, because the right branch is almost double or 3 times than the left.
Yeah, but whichever way, whether you deploy it via the right or the left, the central portion of the valve is going to take the configuration matching the pulmonary artery, isn't it?
Okay.
So it will orientate itself. On the lateral, that looks beautiful compared with the cranial LAO. And there you see on the distal flare is the right pulmonary artery goes into the picture there, and so it's just sitting across it a bit, and that's it. It looks really good.
Shak,
absolutely, the hemodynamics are perfect.
Shak,
Johannes has a question for you.
Shak, the distal flare was not looking very good a short while ago, but the moment they knew that Professor Shak Qureshi is entering the hall, the distal flare reoriented. And for the participants in the hall, let me tell you, Dr. Shak Qureshi was my mentor, and he is the person who is the principal investigator of this venous P valve. and he needs a lot of credit for having made this wonderful valve. I'm again showing the hemodynamics. Show the hemodynamics big. So we have yet another wonderful venous P valve in the other lab. So let me request my colleague to give the PowerPoint presentation of the second patient.
Okay. So you have, well, in our chart we have other patients actually, another pulmonary valve, but you changed the program.
Yeah, because of certain logistic reasons we changed it, and also one of the patients could not be done due to COVID and some related issue.
I see. There is another question for you.
I think the last question from Marcelo Rivarola from Buenos Aires. Would you like to do a angioplasty in the future of the left pulmonary artery, and when?
Was remaining normal, and hence I will not be interested to meddle around in the left pulmonary artery now. If the perfusion difference was more than 30 to 35%, I would have thought about it, but I would like to do it at least after 6 months to 1 year. However, in this patient, I feel I may not do it because it is 60 to 40 is the perfusion. Now, again, let me tell you, the reason why I did a LPA balloon dilatation was to ensure that my distal flare of the venous P is going to fall back from the left pulmonary artery into the confluence without any difficulty. If I had found a significant waste during the ZMED balloon dilatation at 4 to 5 atmospheres, I would have thought about stenting the left pulmonary artery and deploying the valve from the right side. Mario, any thoughts?
Oh yes, that's very good. Then a final question from Johannes for you.
I actually think that's a very good suggestion that you just made, just to review the balloon configuration when you actually dilated the LPA. And the other thing is to consider, do you think that's got an impact on the valve duration, let's say the longevity of the valve performance itself? I actually don't think so, because the gradient is quite little, but again, this is probably something which could be considered in a case where the gradient was higher.
Okay. Nordmeyer, I agree with your point. If there is a significant LPA stenosis, it is going to affect the longevity of the valve, because pulmonary regurgitation tends to be more if there is a distal pulmonary artery stenosis. However, in this particular patient, during the hemodynamics, we were observing that the gradient between the left pulmonary artery and the RV was almost around 9 millimeters. But when I pulled it back into the main pulmonary artery, it reduced to 5. So it's almost like 4 millimeters of mercury across the LPA. So it is not very significant.
Yeah, okay. If there are no additional questions for you, congratulations again.
Thank you.
For an excellent result.
I would like my colleague to now show the PowerPoint presentation of the next patient.